Stage. He's already been up here once today. Lieutenant Colonel Andrew Beckett we'll welcome him back up to the podium, and he's going to be talking about early empiric fibrinogen with some rationale and some clinical data. We'd like to thank Andrew.
Thanks so much for welcoming back. So you're going to hear more about fibrinogen and what's going on with that. So I was asked to do another talk about fibrinogen, which I think is Friday, again on the Canadian experience with our trials, looking at fibrinogen concentrate. So I won't be talking a lot about Canadian fibrinogen trials today. So I think one of the first things about fibrinogen and why it's been an attractive target is it's the first clotting factor to drop. So, and when people show up with a low fibrinogen in the trauma bay, or if you measure in the pre-hospital environment, that person's sick. So that's why it's been a very attractive target, trying to correct this empirically or by ROTEM or viscoelastic guided therapy to try and fix this. So again, looking at these numbers is, when you see somebody coming in, their fibrinogen is less than, it's like 0.5 on a Klaus assay, like this person's in trouble. And whether, one of the things we don't know is correcting that, does that really make a difference? And hopefully some of the upcoming studies will help elucidate some answers for that. So why do people have low fibrinogen when they show up in the trauma bay? For a couple of reasons. One of them is that they've got major tissue injuries, there's consumption of fibrinogen, there's hyperfibrinolysis, and the liver's not working too well. So there's all these reasons why that you're having low endogenous fibrinogen. And the other reason is all the stuff we do to the patient. We take all their clothes off and cool them down. We give them a crystalloid and make them acidotic and dilute their clotting factors, and that also dilutes your functional fibrinogen. So how do we replace it? Cryo versus fibrinogen concentrate. We've heard that debate already today, so I'm not going to belabor some of those parts. But these are some of the things that are going on in this world. Is there is with cryo, you can get transfusion transmitted infections in it, and it's also, there's wide variability in the amount of fibrinogen available, and it's been, a lot of Europe, they just don't use it anymore. And what's nice about it, it's got all the other sticky proteins that may be helpful, and there's also, it's fairly cheap. So a lot of countries like Canada, we've moved to fibrinogen concentrates like Riostab or Fibriga. People have felt it's safer, it's pathogen inactivated, it's ABO universal. And again, it's still being used off label because it's the things on the on label are for congenital or hypofibrinogenemia. One of the things that's nicer about it is, it's stored at room temperature and you can ship around. It's good for 60 months, and it's got a fairly more consistent quantity of fibrinogen in it. So just at the bottom here, this is, the cryostat 1 is 85% of patients could get it into them within an hour and a half, and then with our first one trial, which I'll talk about more Friday, is that like 96% of them got 6 grams into them within an hour. So one of the reasons that we've changed is, is because to give correct low fibrinogen is, correcting with plasma just doesn't work. I mean, it's just too dilute in plasma. And, cryo, it's a little bit difficult to pool and it's a bit messy. I remember trying to pool a cryo in the middle of Africa, and it was just a nightmare. It was like 10 kind of little bags and single donor bags, and then trying to pool it in the middle of Africa, and it was like, it was messy and it was difficult. So but the downside is fibrinogen concentrate is quite expensive. And so just going to go over a quick, what are the products that are available, what's the status of the evidence, and what are the guidelines saying. And I think one of the big things that we keep talking about is with all these things, with TXA and fibrinogen replacement and PCCs, is what's the risk of VTE, and this is the sort of in the background of all these studies. So fibrinogen, so you're going to go with your cryo, plasma, or you're going to use Fibriga or Riastap, and these are the main things on the market today. The little bags of cryo. This is plasma. A bag of plasma, they have about 500 milligrams of fibrinogen in it. At maximum, they're not pathogen reduced or large volume, and you have to use AB plasma as a universal donor, and that's only 4% of donors, as you all know. So cryoprecipitate in Canada, it's still used in Quebec, where I was working for a number of years, but the rest of Canada has moved to fibrinogen concentrates. So anyways, you have to pool it. A pool of 10 in Canada anyways gives you up to 4 grams of fibrinogen. But one thing that really concerns all the blood bankers and transfusion medicine is it's 10 allergenic exposures, and it's not pathogen inactivated. So the two types that we deal with is, like I said, is the Riastap and the Fibriga, and they both, they do the thing that they say they're going to do. People have preferences, and the military, we switched over to Octafarmer's Fibriga because it has arginine in it, and it contains factor 13, and it also doesn't foam up as much as compared to Riastap, which has an albumin in it, and it really kind of foams up when you mix it. We did actually some interesting studies with this, and I'll talk a little bit about it tomorrow. But people, I always heard from the softcom operators that it's such a pain, you can't do this up on the axe, you can't mix it up. But we did some studies where we took Riastap and we reconstituted it, saying before emission, and then we tested it at room temperature and different temperatures and storing conditions, and it's about the same. It tolerates the same conditions as plasma that's not refrigerated, so it's actually fairly stable outside. If you reconstitute it and put it in a fridge, it's good for about 5 days. So these are things you can do with this product. The question is should we go with fibrinogen concentrates, or should we stay with cryo? And that's always the conversation that comes up. There's always been a fear of risk of do you get more VTEs with cryo? And the answer is looks like no. There's never been any differences really shown. More so no thromboembolic events, and I've not seen this, any study that's showing that fibrinogen concentrate is causing more DVTs than cryo. The FIBRES trial, which was a Canadian trial looking at post-cardiac surgery bleeding, and the patients were randomized to either 4 grams of fibrinogen and 10 units of cryo, and then we looked at fibrinogen levels and the adverse outcomes. You can see here is basically there was no real differences in any of the outcomes between fibrinogen concentrate and or any serious events, although it looks like in the fibrinogen concentrate there was a trend towards that, however not significant. And again, that looking in this group is when you looked at the mean number of allergenic blood products, there was a couple subgroups when you excluded the very critically ill and electives, and also in elective surgery patients, that actually patients did better with the fibrinogen. Looking at other studies, for VTEs, cryoprecipitate was shown to be actually more predictive of having a VTE. So that's one of the risk factors is using cryo. So again, not looking at fibrinogen concentrate is one of the main mediators of that. So in trauma, number of studies in trauma with using both Fibriga and Riastap, and in Canada we use both of these for our studies, which I'll talk about more in a couple days. The RETIC study, which was looked at to try and get patients to how many doses it took to get hemostasis in these patients. And it had to be stopped for futility because of the number of patients in the FAP group that required rescue therapy as compared to patients in the clotting factors group. So again, showing that, at least in some settings, that if you're using clotting factors versus plasma, that there may be a role for these type of products in certain settings. And I'm not saying that, basically this is replacing whole blood or plasma, but in these studies, they did show that you were able to reverse trauma-induced coagulopathy with clotting factors. So the efficacy of pre-hospital administration, the FinTech study, it showed that it was feasible in the complex pre-hospital care environment, and it prevented fibrinogen dropping precipitously and promoted clot stability. So again, showing that you can give this in the pre-hospital environment in a randomized clinical trial setting. So FEISTI, I think we've talked about this a lot, and I think we're going to look forward to hearing what the FEISTI-2 the results are going to show. And so I'm not going to belabor this point here. So what do the guidelines state? Looking at, there suggests that you should use viscoelastic testing for trauma. Now, this is inconsistently applied. I can say in Canada, there's only 2 centers in Canada that actually use viscoelastic testing for trauma. In cardiac surgery, some centers will use viscoelastic testing, but most of all in Canada, it's using conventional tests. So basically, people are trying to keep their fibrinogen levels via the Klaus assay above, at least above 1.5, usually around 2. And one of the things from the European guidelines recommending that FFP be avoided for the treatment of low fibrinogen, because you're just not going to get there. It's just there's not enough concentration of fibrinogen in plasma to correct it. Again, showing from the updated European guidelines, showing that again that fibrinogen concentrate plays a role in trying to get the keeping the fibrinogen above 1.5 grams per liter is important, and as well as the initial dose of 4 grams. So I missed a slide here. So anyways, I think this slide's got cut off here for me. Okay. Okay, here we go. So that's great. That until everything came out to this Cryostat-2 study, and I was being a little bit provocative by saying that they were killing people with cryo, and really the trial it was a negative trial. It didn't show anything. So anyways, Kareem Brohi, on the Twitter space drops a bomb saying that possible harm if given very early in penetrating trauma patients, and this set up X chatter all over the place. So, but again, it shows there's really no difference between a standard massive hemorrhage protocol and early cryoprecipitate. So why is that? Well, so when you look at the average time that most patients got it was a little bit later. So very difficult to get cryo into people within an hour. And so when you're looking at this thing, it looked like patients that got it very early did worse. And I think we don't know why yet, and I definitely don't really have any thoughts on that. But I was thinking, with all these other trials using fibrinogen concentrate, you would think if we had given all this fibrinogen, to early in these trials to these patients, we would have seen a signal in all the other trials. Like why is it just this one trial? And again, this thing with the penetrating trauma showing increased mortality that was significant. This was a predefined secondary outcome, so it was not designed to the primary outcome. So that's going to be interesting to explore and find out why that is. And so I'd really open up the floor for any people that have figured that out, but I don't know the answer for that. So a number of studies are actively ongoing looking at cryo alternatives. There's no obvious increase in fibrinogen concentrate. And hemostatically, they look as good as you correct your ROTEM or your TAG on this. There's some guidelines that are supporting their products. And the big question, which I think Feisty-2 is going to answer, is, should it be given, by goal-directed, or should we continue just giving it an empiric? But I think definitely the cryostat-2 has raised concerns about that practice, but maybe the Feisty-2 is going to sort that out. Thanks so much.